Next is about the stroke. Now, stroke, as per the definition, is a clinical term for acute loss of perfusion to the vascular territories of the brain from hemorrhagic or ischemic insults, resulting in ischemia and loss of neurological functions in the affected areas. So, that is a definition of stroke where there is a impaired blood supply. So, it's not only paralysis, that's the important thing. Paralysis produced due to other causes like a space occupying lesion, etc., may not be considered as a stroke. But stroke, when it occurs due to impairment of the blood supply, then it's called as a stroke. Now, as per the incidence, as per the WHO statistics, 15 million people worldwide suffer a stroke each year, and of these 5 million die and another 5 million are left permanently disabled. So it's one of the very critical and serious issue. And from 1992 to 2019, there is an increase in the incidence of the stroke by about 70% of increase in the stroke incidence, 43% increase in the deaths due to stroke, and 102% increase in the stroke prevalence, the existing patients as such. And India is again a very serious issue. The age-adjusted cumulative incidence of stroke is estimated to be 145 per 1 lakh people per year, and it's higher among the women compared to men in India. This is a specialty. And of course, because of the severity of the pathology, the WHO has considered 29th October as the World Stroke Day. So next week we will have that World Stroke Day as such. Now, the global incidence, now there is a geographic epidemic feature also. The incidence of the stroke is more in the eastern part of the world than the western, and India comes at that area where somewhere the incidence is somewhere moderate. It's much more common in a much eastern part of the world as such. Now, as far as the classification of the stroke and the terminologies, there is a lot of confusion. There was a lot of difference of opinion earlier. And American Heart Association and American Stroke Association in 2013, they have cleared a classification model, and it was modified by ICD-10 in 2015. And as per the classification, the stroke can be classified into transient ischemic attack, cerebral infarction, intracerebral hemorrhage, subarachnoid hemorrhage, cerebral thrombosis with infarction. These are the classifications as per the present status of the classification. Earlier, there was a different sort of the classification earlier. Anyway, we'll go into individual type of the strokes as such. The first is the transient ischemic attack. Transient ischemic attack, again, the definition of the transient ischemic attack earlier was like temporary loss of blood flow to the brain lasting for less than 24 hours. That was the earlier, where the patient recovers within 24 hours, that condition could be considered as a transient ischemic attack. That was the earlier definition. But that definition is modified in now 2019, and that current existing definition is a transient episode of neurological dysfunction caused by focal brain, spinal cord or retinal ischemia without acute infarction. The most important thing is there should be no cell death. Then only it's called as a transient ischemic attack. So to make the diagnosis of a transient ischemic attack, now you have to prove that there is no irreversible injury to the brain tissue. It's not only the time factor. That's the important thing. See, earlier it was the time factor which was the criteria to make the diagnosis of transient ischemic attack. But the current criteria, you have to ensure that there is no irreversible damage or no cell death as such, or there is no infarction as such. Of course, the same we may consider this as the pranavta vyana. Sarvendriyanam shunyitam jnata smrti balakshya vyane pranavte lingam karma vitta gurusatragam. So it's the avarana stage as such. Now, as far as the clinical conditions are considered, the most important thing is in a patient present with a history of transient ischemic attack. Of course, the clinical presentation is simple. Patient would have a deficit, neurological deficit, which is for a short duration, and most of the times when the patient comes to the hospital for the examination, he may not have any neurological signs. And the conditions which you need to rule out before you confirm that it is a transient ischemic attack are mainly hypoglycemia, seizure attacks, tumor or mass lesions, migraine with aura, peripheral nerve disorders, neuritis-like conditions, demyelinating diseases, vestibular dysfunctions, intracranial hemorrhage, electrolyte degradations. These need to be ruled out when a patient comes to a history of transient ischemic attack where the patient has recovered completely. There is a need to rule out these conditions by suitable investigations. And the most common causes for the transient attack is atherosclerosis of extracranial carotid or vertebral intracranial arteries. Embolic sources like valvular diseases, ventricular thrombus or thrombus formation from atrial fibrillation or aortic arch disease or paradoxical embolism in patient with foramen ovale, so on. So primarily the basic pathology could be somewhere in the cardiovascular system as such. Arterial dissection, particularly dissecting aneurysm conditions, also can present with the transient ischemic attack. Inflammation of the arteries, arteritis, inflammation of the arteries occurring due to, and particularly in elderly person, and or vasculitis conditions, or at times certain of the drugs also can produce transient attack. Radiation, local injury, or connective tissue disorders like SLE also can be a cause for the transient ischemic attack. Sympathomimetic drugs also can produce transient attacks like cocaine, particularly cocaine, which is also an addiction forming drug. Mass lesions like tumors or hematomas also may initially present with transient symptoms and then result in progressive persistent symptoms as such. Patients with the hypercoagulable status, abnormality of the coagulation, quite commonly seen in polycythemia-like conditions, or cancer or infective pathologies, also transient attacks could occur and they could be the causes. So, important is when a patient presents with the transient ischemic attack, there are not many clinical signs which can be elicited because the patient has recovered completely. But the job is to rule out the other causes which can mimic the attack and to confirm the cause for the transient attack, which requires a elaborate workout for investigations. And most of the times, the investigations and approach is towards the systems other than that of the nervous system. The nervous system examination comes in only to confirm that the patient has recovered completely or there are no neurological deficit. So investigations would be quite important. But the primary investigations, the first thing a patient with a history of transient attack, primary investigations which are absolutely necessary in the beginning itself would be a blood glucose level to rule out hypoglycemia and a total blood count and to identify the possible coagulation disorders, electrolyte levels, and maybe coagulation studies like clotting time, bleeding time, or INR as such. Then ECG to rule out arrhythmias like fibrillation. These are the primary investigations. And once you have done this investigation, and if you have got some clue, you may need further investigations to evaluate the condition, and then the treatment protocol has to be decided based upon that. So there is no question about a standard fixed treatment for the transient attack as such. Now to assess the risk factor, a patient with a transient ischemic attack, there is always a risk factor of having a permanent stroke in such patients. And to assess the risk factor, there are many scoring systems. The most important and most common scoring systems used are either ABCD or California score. The scoring system is simply the factors which are considered in the scoring system are age above 60 years, you have 1 point to be added. Blood pressure, systolic blood pressure, if it is more than 140 or diastolic is more than 90, then again 1 score. Clinical features, in the ABCD score, the clinical features again would have 3 scores, whereas in the California score, that part is not mentioned as such. So that's all the primary difference, but most popular is the ABCD score. If the patient has unilateral weakness, then history of unilateral motor weakness, then 2, speech disturbance is 1, without weakness or other symptoms of neurological deficit, of course, the 0. If the duration is more than 60 minutes, then the score would be 2. If the duration is between 10 to 15 minutes, then score 1. Less than 10 minutes is 0. So a patient having a deficit like symptoms for less than 10 minutes will not be considered as a ischemic attack as such. California score, of course, almost the same issue. There are slightly lesser details, right? And the California score, age is the same. Motor weakness, it's only one set, like one score. Speech disturbance, one score. Duration, it's only 10 minutes or more than 10 minutes, only one criteria. History of diabetes mellitus is one additional factor. Of course, the most common is ABCD score. Now, the scoring system is quite important to identify the possible risk as such. The necessity of that scoring system is to predict whether the patient may have another stroke or another episode within a short duration or a longer duration. As per the statistics, with the AB score, patient with the ABCD score which is less than 3, then there's low score conditions. A possibility of 2 to 7 days, possibility of having a stroke within 2 days is 1.2%, and the possibility of having a stroke by 7 days is 0 to 5.9%, 30 days is 0 to 5.4%, 90 days is 0.3 to 3.2%. So as the time passes by, the risk level reduces. Whereas the patient with the high scores, the within 2 days, the possibility could be 4.9 to 7.9%. 7 days, within 7 days would be 4.2 to 15.9%. 30 days, 6.9 to 17.6%, and 90 days, 11.3 to 18.9% respectively. That's the statistical data as per the current available statistics. The important is this scoring system is necessary to predict whether the patient may have a stroke in the next future or not, and all the target of the treatment would be to prevent that stroke if it is possible. Now the statistics again, irrespective of the severity, the otherwise the data says incidence of stroke is as high as 11% at 7 days in general patient having a transient attack without bothering about the score as such. And this data is from the eastern part of the country, eastern part of the world, in India and China and so on, Japan, so on. So in the eastern part, the risk of a permanent stroke is higher than that global average, and this data is about that part, and it's around 11% within 7 days. And the probability of stroke in 5 years following transient attack is around 24 to 29%, and the risk is much higher if the patient has a coronary artery disease. That's about the data related to our conditions, like eastern part of the world. Now, as far as the treatment protocol is concerned, the treatment, there is, as I told you, there is absolutely no defined method of treatment. All the target will be to prevent another stroke. And of course, the other part of the treatment will be, once you have identified the primary cause may have to be treated. The primary cause, like if the patient has a fibrillation, you may have to give the antifibrillatory drugs. If the patient has hypertension has to be corrected. Diabetes, it has to be corrected, and so on. So that's one part which we will not be able to reach out with. The other part is about the general approach of the management to prevent another stroke. For prevention of the acute stroke, the important is about the prevention factor. The most dependable line of treatment to prevent the stroke is platelet aggregation inhibitors, to prevent another clotting as such, which is a general protocol. And the only thing is, it has to be confirmed that there is no intracranial hemorrhage before you start with the antiplatelet treatment or platelet aggregation inhibitor treatment. So there may be all that investigations may be necessary to prevent to rule out intracranial hemorrhage before you start with the anticoagulant treatment. And the treatment protocol is mainly either aspirin or aspirin with the dipyridamole or clopidogrel, the newer generation of the drug. Again, aspirin dosage, again, there is a difference of opinion among the neurologists between 50 to 325 milligram per day. But the most effective and safe dose would be 75 milligram per day is the safest dose, which will have a cardioprotective activity, as well as the risk of bleeding occurring later would be lesser, and that can be used as a general issue. Specified higher doses may be required only when there is some specific indication. The mechanism of action of aspirin is it blocks prostaglandin synthase as such, and hence it inhibits the formation of platelet aggregation, particularly thromboxane A2, which is necessary for the aggregation of the platelet, that's inhibited. The risk of a bleeding disorder would be lesser. Whereas the other popular drug, clopidogrel, it selectively inhibits adenosine diphosphate, and it's a platelet receptor and subsequent ADP mediated activation. It has a prolonged activity. See, with the aspirin, the platelet aggregation inhibitor activity lasts for around 1 to 2 days. Once you withdraw the drug, that effect would be reduced by 1 to 2 days in case of aspirin. With the clopidogrel, the inhibitory activity lasts for about 7 days, and this is quite important. From the other part, like a patient who is on aspirin or clopidogrel, if we have to do any surgery or any surgical intervention, withdrawal of these drugs is important to reduce the possibility of bleeding, and with the aspirin, a withdrawal period of 1 to 2 days would be enough, whereas the clopidogrel, you need to withdraw it for about a week. That's all the importance. Otherwise, as far as the clinical effectivity is considered, clopidogrel is considered to be more effective than the aspirin. Then the combination of aspirin with dipyridamole is also another of the options, which is generally not preferred, not very popular, but in certain specific cases where the patient has a high possibility of the coagulation disorder, this combination is often used, dipyridamole and aspirin combination. And dipyridamole prevents the adhesion inhibitor. It actually prevents the platelet adhesion, and it also reduces the fragility of the RBCs by blocking the uptake of adenosine, and hence this is considered more specific as such. So that's one. Then another aspect of management of this transient attack is blood pressure management. This again is a controversial issue. Earlier, in the earlier protocol, antihypertensive drugs also were considered as a primary part of the treatment. But now it's known, like it's not that the blood pressure should be reduced drastically. Only when the blood pressure is very high, like 220 to 120 milligram, and then only there is a need for reducing the blood pressure rapidly. You have to give some antihypertensive drugs. But otherwise, if the patient has a relatively stable level of blood pressure, and there is no definite cardiac involvement at that moment, antihypertensive drugs are not given immediately, or you may have to give antihypertensive drugs gradually so that the blood pressure doesn't get reduced immediately. Rapid reduction of the blood pressure is not ideal as such. So usually centrally acting drugs like clonidine are not preferred at that moment if the blood pressure is high. Either calcium channel blockers or beta blockers, calcium channel blockers like nifedipine or beta blockers like atenolol, they are the generally preferred line of the treatment in case of the hypertension. If the patient is already non-hypertensive and the patient is on antihypertensive drugs, you have to ensure that the blood pressure is at the moderate level, not very low level in such patients of the transient attacks as such. But long-term maintenance of the blood pressure has a very significant value in prevention of the further stroke as such. In patients with as far as aspirin dosage is concerned, higher dose of aspirin is preferred in the patients who have atrial fibrillation with a transient attack, and long-term anticoagulation. Maybe at times the platelet aggregation inhibitor may not be enough. Anticoagulant like warfarin also may be necessary, and keeping the INR ratio, that the bleeding time at a higher level, the clotting has to be inhibited significantly. Keeping the INR level at 2 to 3 may be necessary in case of atrial fibrillation, and particularly in the patients where they cannot take oral anticoagulants. And in patients with myocardial infarction and then transient attack followed by the oral anticoagulation with the warfarin and aspirin both may be required as such to treat that coronary disease. Of course, with the coronary artery disease, you will have more detailed protocol of treatment in case of myocardial ischemia. But in the immediate issue of managing a patient of transient attack with a history of myocardial infarction, anticoagulant has to be given, and there the dosage of anticoagulant and the upper limit of the ANR also is higher. And patients with cardiomyopathy also, the anticoagulant with warfarin and antiplatelet therapy may be necessary. In the rheumatic mitral valve diseases, they again warfarin may be required, and in all these conditions only, the ANR has to be kept at a level of 2 to 3. Otherwise, any patient of the anticoagulant treatment, the ANR should not be allowed to go beyond 1.5. That's the general rule. In these conditions, this is an exception to prevent the recurrence. Otherwise, anticoagulants are necessary. Only platelet aggregation inhibitors are enough. And long-term monitoring of TIA patient, the most important is, as I said, antihypertensive control, particularly optimized for the patient with the hypertension. If the patient has a hypertension, that has to be corrected. Then statistics also says that lipid control should be initiated, particularly with the statin agent. Now, these days it has become a very popular issue. Statins are regularly prescribed to control the lipid in the patients who have abnormal lipid profile. But what we have observed is statins are not really much beneficial otherwise, but this is the standard guideline as per the standard protocol. Control of blood glucose level optimum should be in patients of diabetes. So that's the major part of the treatment of transient attacks. Patients with the smoking history, smoking cessation has to be done, which may also include some medications if necessary. Drunkards should eliminate or stop alcohol consumption. Overweight patients should be encouraged to lose the weight, and all patients should be encouraged to do the exercise. This is the guideline given by the American Heart Association in patients with the transient attack as such. As far as our prescriptions, which I do, would be patients with the transient attack, the ecosprin and antihypertensive protocol. We do follow, it's necessary, and along with that, our treatment would be Chandraprabha, Ekanvirus or Suvarishta. Most of the patients that can be managed only with these drugs. Selective patients may be even treated with the Agnichikitsa and Matrabasti, which is a real treatment which is given in case of stroke. That's the absolute treatment for the stroke. It's not essential that every patient of TIA should be subjected to this. Prolonged treatment with the Chandraprabha, Ekanvirus or Suvarishta, considering this as a Pranamurtabhyana, can be enough. Of course, the other part like dosage of glucosamine and antihypertensive would be necessary. That's about the transient attack. The next is about the ischemic stroke, which is again quite common among the patients whom we treat. Now, ischemic stroke, earlier the classification would be as ischemia produced through thrombosis or embolism. Now, the recent classification, it gives much more detail about the ischemic stroke as large artery ischemia, small vessel or lacunar infarction, cardioembolic infarction. So, thrombosis produced would be of either large artery or small vessel, which will have some differences in the clinical presentation as well as outcome. And cardioembolic infarction, that's the issue. Basically, the difference between a thrombosis and an embolism would be from the clinical presentation point of view. Embolism would be usually presented with the sudden onset of the stroke symptoms, whereas thrombosis, there will be usually gradual step-by-step enhancement, progressive pathology. So patients of thrombosis usually starts presenting with the gradual onset of a neurological deficit anywhere, any sort of the neurological deficit, which may gradually go on increasing, and it may take some time, like hours or days, also may have a full-fledged stroke. Whereas patients with the embolism, the occurrence would be somewhat sudden. Just a minute. Mm. Patients with the embolism would have a sudden onset of the symptoms. That's the basic clinical differentiation. But at times, presentation may not be very absolute. You may have to have the investigations to confirm about that. So that's a basic difference. In a case of embolism, there will be a blockade suddenly due to the embolus starting from somewhere and blocking the vessel. The other is about the infarction, hemorrhage. The hemorrhagic stroke is the other part of the issue, which we will discuss separately. We will discuss ischemic stroke as such. Now, patients presents with the clinical symptoms, and the symptoms of stroke could be any of these. It's not necessary that it should be only hemiplegia. So, though majority of the patients will be presenting with the hemiparesis or hemiplegia, hemiparesis where there is a partial loss of movement in half of the body, and it could be either abrupt, as said, abrupt in case of embolism or progressive in case of thrombosis. It need not be only hemiparesis, it could be monoparesis, any one organ, any one part of the body could be involved, or it could be all the four limbs involved. Or there could be sensory deficits. Patients may have loss of sensation in some areas. Not necessarily that every patient of stroke would have a motor deficit, though majority of the patients, more than 80% of the patients would present with the hemiplegia or hemiparesis. The other presentations could be sensory deficits also could be presented, or visual loss, where the patient may have visual loss of one or maybe both eyes, or visual field deficit, or diplopia. Abnormalities of the vision occurring suddenly in such patients can also be presentation of the stroke. So the important is a patient presenting with these symptoms, it is necessary that you have to go for all the investigational workout to confirm whether it is due to the stroke or other causes. See, these presentations can occur due to other causes also. Or it could be dysarthria, where the patient may have difficulty in the speech, droop of the fascia, or these attacks, a gait abnormality, vertigo, rarely in isolation, particularly in when the patient is in a very specific. Of course, vertigo along with the other symptoms is common, but vertigo alone can also be a symptom of stroke occasionally. Nystagmus, aphasia, complete loss of speech, also decrease in the level of consciousness also can be presentation of a established stroke as such. And of course, majority of the patients present with the either hemiparesis or hemiplegia, then loss of consciousness, dysarthria or aphasia depending upon the area of the brain which is involved. Now, to assess the severity of the stroke, which is also quite important, the the scale, health stroke scale, National Institute of Health Stroke Scale, NIHS scale, is most popularly used, and this is considered to be the benchmark for assessing this. And the criteria is one is level of consciousness. See, and the level of consciousness, if the patient is alert, fully alert, 0, score is 0. If the patient is drowsy, 1, stuporous, 2, patient is under coma, the score is 3. Patient's response on question, like level of consciousness, to response to questions like the age, or which is a month or day, or so on, or any of the issues which could be related to the memory, assessment memory and coordination of the patient. If the patient gives answers to both the questions correctly, 0. If patient answers one correctly and the other is incorrect, then score 1. If both are incorrect or not able to correct answer these questions, then the answer score is 2. Then level of consciousness is set by commands, like asking the patient to do certain movements, like usual what we do in the regular practice is asking the patient to close the eyes, grip the hand and release the hand. Again, the hand on the other side, not the hand which is affected, on the other side you have to see to assess whether there is a high risk of stroke enhancing or not. If the patient can do these exercises correctly, both the activities, then the score is 0. If the patient is able to execute one activity and the other is not there, it's a 1, score is 1. If the patient is not able to do any of these, then the score would be 2. And the patient, the other examination would be best gaze, or asking the patient to look at a moving object, maybe the fingers, And if the patient is able to look at the moving object, the score is 0. If the patient is having a partial gaze palsy, he is not able to move only to the full extent, half of the area, then its score is 1. If the patient cannot move the eyeball, but she has to move the head as such, then its the score is 2. Visual field is another part. If the patient has no visual loss in eval, then it's 0. Partial hemianopia, if there is a slight reduction in the field of vision in one side, then it's a score is 1. If there is a complete loss of the vision or visual field, reduction of the visual field on one side, its score is 2. If the patient has a significant visual field reduction in its both bilateral hemianopia, the score is 3. Both these gaze and visual examination can be done with a single test, like moving your finger across the eyeball and ask the patient to look at. Then to evidence of the facial palsy, ask the patient to show teeth or raise the eyebrows or squeeze the eyes shut. If the patient is having these normal activities, it's 0, minor deviation 1, partial deviation 2, complete all the functions are lost, then 3. Then the motor arm, the motor activities of both right and left side has to be studied, and if the patient is able to raise up to 90% and hold it to 10 seconds, this is the usual protocol. Ask the patient to raise the arm and hold up to 10 seconds. If the patient is able to hold that without any drift, then 0. If there is a partial drift, 1. Cannot resist gravity, cannot just raise against the gravity at all, but he attempts to lift up, then it's the score is 2. If the patient is not able to lift at all against the gravity, no effort is seen, then 3. And absolute no movement, flaccid, then its score is 4. And this is done specifically for the both right and the left arm, and the score has to be noted. And similarly, the motor activity for the leg, it's again raise up to 30 degrees and hold for 5 seconds. That's the basic baseline. And again, similar issue, the scores have to be done. And for both left and right, you have to do this. Then the next is the ataxias, limb ataxias, particularly finger nose and heel chin test. Finger nose test and heel chin test we have already discussed when we have discussed about the examination of the nervous system. If again the score is 0 is absent, 1 is present, that's if no abnormalities, 0. If the symptoms are present mainly in one limb, then its score is 1, and the present in both the limbs, its score is 2. Sensory, like pinpricks to arms and legs, to examine the sensation also is important. A normal 0, partial loss 2, severe loss, partial loss 1, severe loss 2. Then the extinction or neglect, if the patient is not able to relate to the surroundings, patient is not responding at all to the questions, or patient is not really bothered about the surroundings, then if there is no such evidence, then 0. If there is a partial neglect, it is 1, and if there is a complete neglect, it is 2. Dysarthria, speech clarity, and usually the words used to be these consonants, like where the patient has to have the lip movement, like mama or 50-50 and so on. So any amma, that's the word. Or maybe ask the patient to repeat the names. Now, if the patient has a dysarthria of that sort, and it is a severe and not eligible, then it's the score is 2, and if it is mild, 1, and normal articulation 0. And the patient can utter the names of items and describe, can have orientation and form a sentence as such, then it's called a 0 score. And if it is not possible at all, score is 3, and this is about the issue. Now when you sum up the score, then you can have the levels of the stroke severity. Of course, 0 is no stroke symptoms, 1 to 4 minor stroke, 5 to 15 moderate, and 16 to 20 moderate to severe, 21 to 40 to severe stroke. This grading is quite important to predict the prognosis and plan the management. Patients who have the fourth category, that's moderate to severe stroke to severe stroke, they need life support systems. They need life support systems, whereas the other minor strokes they can be managed without the life support systems. They can be managed as such. So, to the primary issue in a patient presenting with a stroke is whether you need to have life support. When I say life support system, the mildest would be like a rail tube insertion, catheterization, or oxygen supply, or ventilation, severe ventilator. Any of these, ventilatory support, any of these may be required. If the patient has a minor stroke or a moderate one, these may not be necessary. In the patients who have severe stroke conditions, the last two categories, those may be necessary. So whether you manage the patient of stroke in your setup or you refer the patient to some other setup would be depending upon the facilities available. If you do not have the facilities for that life support of higher degrees, then it's better to refer the patient to a facility where it is available. Now once the ischemia has occurred, the pathological changes which occur in the brain would be the ischemia would occur at some areas and there could be cell death. But the more significant would be the tissues around the area, nerve cells around the area also would be affected, and there will be a partial ischemic changes around the area, and this is what we call as the penumbra effect. And hence, when we examine the patient's nervous system examination and localize the pathology, the area involved may look to be wider. There could be a significant extension of the deficit of the nerves or malfunctioning of the nerves seen in these areas where the patient may have any ischemic changes. The blood flow could be reduced. The surrounding peripheral areas, nerves, though they may have a normal blood supply, still there could be some excitatory response. There could be an abnormal response produced at that area, and all these would add to the clinical presentation. And in the so the primary total neurological deficit will be at this area. The penumbra area, the nerves would be not functioning properly, but still they are alive, they are not dead, and there is a possibility of recovering them. And this also has a significance in the management of the stroke. The immediate management of the stroke, the immediate aim of the management of the stroke is to safeguard these penumbra cells, to prevent their further damage, because they are at a high risk of having irreversible damage, and that should be prevented. And that's exactly when we go into the details of protocol of treatment of ischemia, this comes in. Then there is some abnormality of the excitatory function of the peripheral tissues because of abnormal conduction, and this also need to be taken care of. The total pathological changes which occur could be, the moment there is an ischemia, the first of the thing which would occur would be there will be excitotoxicity. That nerve cell would not be able to function properly, and there will be accumulation of the glutamate, the ischemic chemicals which are produced. Then the next would be, there will be a sign for the cell death, because the nerve tissues are totally dependent on oxygen, and within a few minutes they tend to die, and the initial there will be the release of the substances which will produce the cell death, and this is what we call as autophagosomes. We categorize them as autophagosomes, and this phenomena is called as apoptosis, where nerve cells are dead as such. Then the next part is, once the cells are dead, the next part is they need to be dissolved, and there has to be new formation of the cells. So for this, the body would be trying to have the inflammation, neural inflammation, which is to remove that tissue. There will be lots of cytokines released. All the immune cells like lymphocytes, they come to the area, they try to engulf that area and remove the debris of the nerve tissues. Then there will be oxidative stress. The mitochondria in the surrounding area will be dysfunctioning. So the sequence of the events which occur after the ischemia would be progressive. This also has a clinical presentation, significance of the clinical presentation. Till the patient has that cytokine release, the surrounding cells, particularly the penumbra cells, would not be able to function, and hence there will be a flaccidity seen. Once that stage is over and there is an attempt to bring in some new cells, and that progression of the cytokine release is reduced, the flaccidity reduces and the muscle tone would be increased. There will be a spastic state. And this has a significance from Ayurvedic point of view, and at the end I will come to that part. Like the patients present with the Sama Lakshanas, they are at this stage, till this stage of cytokine release, it is the Sama Lakshana. Once the cytokine release stage is over, then it will be the Nirama Lakshana, and this has a significance from the management point of view, from Ayurvedic point of view also. Whereas from the contemporary science point of view also, it is also quite significant. The risk of progression of the disease and producing more complications would be more till this cytokine release phase is over. Time taken for that cytokine release phase again is variable from patient to patient, and the major effort of the treatment, target of the treatment will be to reduce the duration and to reduce the possibility of these complications as in stroke patients. Now, the most important part in the clinical diagnosis is the confirmation of the diagnosis. Of course, clinical evidence, of course, in all the cases of stroke, the primary and most dependable sign is the clinical examination. And the clinical examination confirms the signs, and majority of the conditions, the location of the pathology also can be accurately made out with the clinical examination. But the other way, the investigations which are required could be, you may need to have any significant line of investigations depending upon the condition. Certain of the basic factors, I will not go into very high details, I will just minimize the details as certain of the basic factors which you have to consider are the CT scan is the primary investigation in such conditions of the stroke to confirm the diagnosis. And again, the CT scan, to show the signs of the CT scan, there should be a cell necrosis. And if cell necrosis doesn't occur, the CT scan may not show the abnormality. In majority of the moderate stroke conditions, the cell necrosis can be seen only after 24 hours. Up to 24 hours, the cells may not be showing the damage. Of course, in some patients where there is a massive ischemia, the necrosis may occur within a short duration. So, majority of the patients, at the time of admission, if you go for CT scan, there may not be any abnormality. But if you repeat the CT scan after 24 hours, if you show the scan after 24 hours, the signs of ischemia may be seen as the area where the cell density has become reduced, necrosis has reduced. By 48 hours, the same lesion could be well established, and the changes of the penumbra also can be made out. The ischemia as well as the penumbra changes can be made out. And hence, wherever possible, it is always better to go for the CT scan after minimum of 24 hours or 48 hours after the onset of the stroke. That's a safe sign. Of course, it may be necessary in some conditions where you have to go for the CT scan immediately, and it's not a general rule that the CT scan should not be done in the early hours. But the point is, the observations made on the CT scan done immediately after the stroke may not really give the correct picture. To have the correct clinical picture, you have to have the CT scan after 24 or 48 hours after the injury. Now, the changes which occur due to the ischemia, again, may not be very significant, particularly ischemic stroke, lacunar changes, I'll come to that part, may not be easily observed in CT. Many times, the CT may not be showing the changes very accurately. MRI scan may be necessary. In the CT, it must be seen as a reduced density of the tissue, whereas a MRI can show you the changes much more remarkably. The changes of ischemia due to that free blood flow and the edema of the tissue can be better seen in MRI. So, MRI scan could be better. See, ischemia of course can be seen in CT, but the point or the observatory signs in ischemia or in CT may not be showing the exact intensity, severity of the lesions in as such. But CT is quite useful to identify any hemorrhagic patients, and hence it's necessary that you have to go for the CT in the primary, and if the information is not sufficient, then MRI may be necessary to confirm these lesions, MRI scan, and particularly if there is some suspicion about the other possibilities. So, ischemia is not very clear-cut evident. If there is a sign, maybe possibility of other tumor-like conditions, MRI may be necessary. The picture which you see in MRI would be different from what you see in the CT. See, in the CT, the extent of ischemia in this image is limited to the parietal lobe area, but MRI shows that the same extensive. In the second picture, the ischemia shows that there is some sort of the cell damage, but there is a regeneration process or reperfusion process. The density shows that there is a reperfusion process in MRI. So the information you get in MRI would be much more informative than CT. But many times you may have to go for other very sophisticated investigations which are now currently available in very sophisticated centers. In the routine conditions like our setup, this may be irrelevant, but the other, for the sake of theory, now this is for us it is a theory, but for the sake of theory, the other options of the investigation to confirm the diagnosis of an ischemia, to differentiate it from the other conditions, would be, of course, a CT scan within 4 to 5 years. This is a sequence of pictures of different investigation set up of a single patient at some day, collected from some source as such, which gives you a clarity of the need for the specific investigations. The investigation like a simple CT with the contrast may not show very significant abnormality as such, may seem to be normal within 4 to 5 years after the onset of the symptom, did not show any evidence of infarction. But simultaneously, if a CT with perfusion with the study of the perfusion studies shows that there is a delayed perfusion, the blood flow is reduced. So perfusion study, CT perfusion study may be necessary. Of course, CT perfusion facilities may not be available in our setup. So for us, it's only theory, as I told you. But this kind of a facility is available which can make out. If you have a cerebral blood flow map technology, these are all computerized CT scan advanced technologies, variations, it can confirm that hypoperfusion in the areas, brain region as such. CT angiogram, the other way, where you have a three-dimensional directions pictures like in these two pictures of the three angiograms, it can show the branches absence of the blood flow in the branch as such, the left middle cerebral artery branch being blocked. A MRI scan done after in the same patient, MRI scan done after 4 days shows the typical this infarction. So the different technologies of investigations which are advanced now, and neuroimaging itself is now a new branch asset which I just referred to in the earlier classes also. And with all that advanced technology, the diagnosis can be very accurate and exactly localized. Now, the other basic issue, patients have an ischemia, ischemic brain changes. The changes which are seen in MRI may be of different pattern, like if there is a small infarction, it may be seen as a simple opaque spot, whereas a bigger infarction and the ischemia with a delay where there is a penumbra changes, like the tissues which are edematous, you may have a hyper this white matter density with a hyper intensity as such. Later on, the same condition as the reperfusion occurs and the cell death occurs, that will be seen as lacunae. We use the term lacunar infarct. Lacunar infarct suggests that there is a cell death already has occurred and the blood flow has become somewhat reduced, significantly reduced at that area and stabilized. Or it could be seen as a hollow area, perivascular space, because that area is completely damaged and even that area cell depth is occupied by some fibrous tissue. So you may see these kinds of lines seen in the later stages. Usually it's after about 2 to 3 months as such. Then there could be microbleeds, multiple small bleeds could occur in such patients. These are the usual radiological signs seen in MRI scan, and the diameters, the size of these can vary as such. So along with that, the same signs may be seen in different technologies. Suppose you modify this technology into diffusion wave imaging or FLAIR technology or susceptibility wave imaging, like or gradient record imaging. These signs may be seen or may not be seen as such. That's all the point. You may be able to see that. Of course, this may not be necessary from your point of view. From our basic point of view, these changes which can occur in the ischemia are important. Then that's about particularly in the thrombosis, embolism, thrombosis conditions. Now in the thrombosis, the other part would be which of the vessel is blocked. That need to be known if at all you are going for interventional treatment. Of course, from our early treatment that may not be necessary. But interventional treatment may require this, and for this you may need to have angiography. Angiography will show the different changes in the vessels. Either it could be a complete blockade, occlusion of a vessel where there is no blood flow at all, or it could be like a artery will become narrowed and there will be diffuse as such, or simply hemodynamic impairment. The density of the blood flow in one side could be lesser than the other, or it could be like erythematosis where the vessels are narrowed. So any of these changes could be seen in the angiogram. That would be the necessary, particularly in the small vessel disorders. Now, and majority of the patients whom we see in the old age are of the small vessel disorders. And in these conditions, it's about the lacunar changes which could be seen at the different stages as such. Early stage lacunar infarctions, and in the later stages, the lacuna becomes somewhat thinner and the surrounding area will be reduced. Rarely, a lacunar infarction may become cystic. There will be a fluid form, and that fluid could be accumulated in the area, and you may have a fluid filled cavity which is a cystic degenerative changes. Rarely it may occur as such. That's about certain of the changes, like a patient having acute infarction uh, where the image is seen in 3 days. 1 year later, that gets reabsorbed and becomes a lacuna. This is about the usual field asset. Whereas in case of extracranial large artery thrombosis, the opacities are seen as a large area opacities, and the penumbra effect is comparatively lesser in large artery conditions. And that large artery conditions are better diagnosed with the angiogram which are necessary. These are all of the series of investigations which are necessary, may not be absolutely necessary. Now coming to the management of the stroke. Management of the stroke has a different views or different aspects, like the first of the thing is the acute management of stroke. A patient presenting with a stroke, the immediate management, the first and foremost would be the vital functions have to be taken care of, and the targets would be optimization of blood pressure, ensure that the patient has sufficient oxygen. Even you have to confirm whether the patient has hypo or hyperglycemia, and that has to be corrected. And another important part is reduction of the cerebral edema. These are the options which are available for a routine clinical practitioner. More sophisticated in innate management techniques, which are now more popular in the Western countries, and in India, very few facilities have this kind of a setup. Could be the fibrinolytic therapy, where the fibrinolytic agent could be injected in. Uh, Earlier it was streptokinase, the same which was used for MI, but now it's known that streptokinase is not going to be useful. But another one that alter place is now the usually used substance, where the catheter is introduced and the fibrinolytic drug is injected to the area. But this should be done within 4 to 8 hours of the stroke. And of course, from our point of view, this becomes really a majority of the patients will not come to the hospital within 4 to 8 hours, and getting an opportunity for that kind of a therapy is not possible. Moreover, the facilities also are not available. So I have put in these in the red color because these are only part of the theory now for our situation. Ultrasound therapy or thrombectomy, surgical treatment, would be the other options as such. Now, as far as the guidelines, now the AHA guidelines, American Heart Association guidelines, these are quite important. Uh, Giving aspirin 312 milligram orally within 24 to 48 hours of ischemic stroke onset. Now, of course, the latest guideline is about the fibrinolytic therapy. I will not go into that. I am just coming to the guideline which is somewhat older but relevant from our issue. One is aspirin given in high doses only after ruling out the hemorrhagic stroke. You have to rule out the hemorrhagic stroke. That hemorrhagic stroke is something which we discuss in the next. But aspirin should be given 24 to 48 hours, and the guideline is 325 milligram. But what I would say is again 75 milligram is safer, and it involves reduction of recurrent stroke. Then 2013 guidelines again, systolic blood pressure higher than 220 milligram or diastolic blood pressure above 120 milligram, that needs to be treated immediately, and other patients sudden reduction of the blood pressure is not to be given, and care must be taken not to lower the blood pressure too quickly or aggressively, and hence the centrally acting drugs are generally not preferable. It's always better to use a relatively milder drugs like calcium channel blockers or beta blockers, they could be used as such. And there is a bit of controversy, like some of the, you will have plenty of research articles which plead for calcium channel blockers, some of the articles plead for central acting drugs, some maybe have beta blockers. My experience, when I treat majority of the patients, I would always prefer calcium channel blockers like nifedipine as the drug of choice, which gives somewhat better, more dependent results, and the risk of hypotension and the possible ischemia produced due to the hypotension, what we call as a reperfusion injury, that would be lesser with that calcium channel blocker. That's what I prefer. Of course, there are plenty of research articles which are also coming which say that calcium channel blockers will produce more harm than the others. So that area is a bit controversial. Final issue is not yet made out. Then another important issue is that patients may have a high body temperature, particularly in the first 12 to 24 hours after the stroke onset. It has been associated with the significant poor functional outcome, and there is administering so-called antipyretics like paracetamol. They may not have the same advantage. Rather, it's better to have a reduction of the temperature by hypothermia. And now many experimental evidences have suggested that hypothermia, reduction of the temperature by keeping a cool pad over the head, would be much better than the antipyretic drugs, and these are in the different stage clinical trials. As far as some of our folk therapies, local therapies, many people prefer to have cold water, that Shita Jaladhara, as a protocol of the treatment is in stroke. It has a relevance in reduction of the temperature. Then the other part is about edema control, reduction of the cerebral edema, particularly cerebral edema and damage to the penumbra tissues. A significant cerebral edema after ischemic stroke is thought to be somewhat rare earlier, but it occurs quite frequently, and majority of patients, the edema is reaching the peak by around 72 hours as such. The options of the treatment to reduce the cerebral edema has the main is glucocorticoids, which I would always prefer. Glucocorticoids are safer, but now lots of controversies are coming up. Lots of research articles which say that the glucocorticoids are not really helpful, but still, from our clinical point of view, that's the most dependable drug. Of course, some of the patients may not respond to glucocorticoids, but if the patient responds to glucocorticoids, the response will be quite good. So usually my protocol would be, in the first 2 days after the onset of the stroke, I would be preferring to supplement glucocorticoids like dexamethasone, short-acting drugs for first 2 days, so that the possibility of the cerebral edema gets reduced and the patient becomes somewhat coordinated. And once the patient is fully coordinated, the signs of edema are reduced, then there is no need of continuing glucocorticoids. The majority of the controversy is about prolonged use of the glucocorticoids, not for the short duration. Anyway, there could be, if you go into the different articles, there are many articles which are presented which seem to be against the norm of prescribing glucocorticoids. That's also true. Then the other option is the asthmatic diuretics like mannitol. But mannitol has a very limited options. Only in those patients where there is a traumatic edema, mannitol would be very useful. But in case of the ischemic conditions, mannitol or other such asthmatic diuretics would not be preferred. The other advanced option would be craniectomy, where the skull bone portion is removed so that there will be no edema as such. But this is again a very advanced technique and has a very limited scope as such. Then another of the complications which can occur as a result of the stroke is seizures. Seizures may occur in 2 to 23% of the patients within first days after ischemic stroke, and these could be focal. And these need to have a treatment. Then there is a controversy like whether all the patients of stroke have to be given anti-epileptic drugs or not. The general guideline is not to give anti-epileptic drugs unless the patient has evidence of the epilepsy. But many of the neurologists now, they have made it as a rule, like any patient with a stroke, an anti-epileptic drug is given. So when the patient comes to us, my treatment is I will not give the anti-epileptic drugs unless the patient has developed seizures, and they may not be necessary. But if the patient comes with an anti-epileptic drug and where the history is not very clear, like whether the patient had really a seizure or not, it's better not to withdraw that antiepileptic drugs immediately. Then the other part is anticoagulant therapy. The anticoagulant like heparin being used as a, or warfarin also, heparin intravenous or warfarin. As far as the management and the outcome is concerned, there is a lot of controversy. It's not justified that you use the anticoagulant treatment in every patient. Anticoagulant treatment is preferred only in the patients who have atrial fibrillation. In other conditions, it may not be necessary as such. Then in all the patients of stroke, there is always a risk of reperfusion injury, and that reperfusion injury is presented with the clinical symptoms of headache or neurological deficits expanding in the other side, seizures, which is again produced due to the edema, cerebral edema occurring in the later stages as such, and there again the outcome would be poor. The general treatment protocol, to summarize, would be the same. Take care of the vital functions, anticoagulant, ensure that the blood flow is becoming normal, antiprotective, and there is another new group of drugs which are now being prescribed as neuroprotective, but they are extremely new drugs and their limitations are not known. From Ayurvedic point of view, all the strokes may be considered as a Pakshaghata, and the difficult description is a Siraha Snayu Shoshacha. There is an abnormality of the vessels, and hence which results in the abnormality of the nerve tissues, and it may be presented with either Ekanga or Sarvanga Roga as such. And the prediction of the prognosis is based upon the two important issues. One is whether there is a Kevalavata or Avaranajanya. Avaranajanya Mata is always better to be treated than the Kevalavata Lakshana. Avaranajanya Mata presents with the signs of flaccidity, and in such conditions, Daha Santapa Murchasri Vayo Pitta Samandite, Shaitya Shota Gurutvani Tasmineva Kapanvide. These are the signs of the Avarana, and Shuddha Vata, the Kevala Vata, is considered as a Asadhya. And the treatment is Kevalam Nidipastambam Adav Snehi Upataret. General treatment of Snehana of Vata Chikitsa should be done only in the Nidipastam stage, later stages, though in Vambhata, the general line of treatment is considered Snehanam, Snesiktam, Pakshagati, Virechal. My preference of prescription would be in all the patients of stroke, considering the other protocols like hypertension, coagulant, and the other parts. They are absolutely necessary, cannot neglect them. My prescriptions would be along with those protocols which we have already referred to, Chandraprabha, Ekangvira, Abrakatapya, Godangavipatigaraturna, to reduce the possibility of Dhatukshaya there, and Agnichikitsa with Matravasti in the flaccid stage, in the Sama state, and Pindasveda and Brahmanavasti in the spastic stage. Virechana in very chronic conditions where the patient has become developed contractures. This is about the protocol which I would prefer, and with this we will conclude today the ischemic stroke. The next part we will start with the other types of the stroke and their management approach and issues related to the neurological diagnosis. There are no questions, so okay, thank you, sir.
Thank you, sir.